Hi, everyone. Welcome to our September ICARE case conference. I'm Tua Pal, and I'm going to start off with a little bit of housekeeping first before going into our very interesting topic today. So just wanted to thank everyone for referring to ICARE. As you already know, we have several ways that you can refer your patients, either through the website or through prepaid postcards, which we're happy to send to you. And then the other thing is we really appreciate all of our partners who submit cases, and we've tried to make it as easy as possible. So again, it's on our website if you want to submit a case that you want to discuss, whether it's interesting or complex, etc. So please continue to submit cases. Just some resources that many of you already know about. We're having our virtual case conference, so we have these monthly. We also do biannual newsletters with clinical and research updates. We have a lot of resources on our website that are searchable, and then we are active on social media as well. And these are just some of the posts that we've done over the past month, which includes talks, newsletters, open studies that folks may be interested in, as well as stories, research updates, and guideline updates. Some of the ICARE focused efforts, we're still continuing to recruit for our impact study, which is testing strategies for enhancing cancer risk management, as well as family communication among individuals with inherited cancer. So the segue into this study is through ICARE, so please continue to refer your patients. Myself and my colleague, Dr. Sonia Reed, are working on a genomics of breast cancer study, again, focused on the inherited breast cancer genes, where we're doing sequencing of both tumor and germline DNA, tumor RNA as well. So again, please continue to refer to ICARE. I just wanted to highlight a few upcoming conferences. There is a conference happening in Toronto that's available both via Zoom or in person. There's a provider focus conference on November 4th, as well as a patient and public focus conference on November 5th that you can publicize to your patients. And again, there's quite a nice lineup of speakers. It's in honor of Dr. Stephen Narod. And again, anyone that's interested, we can send some information out after our case conference as well. We do have some future patient forums that we've organized. Our October one is scheduled for October 29th. And we have both our Cancer Center Director, Dr. Ben Park, as well as Harvey Singer and Vicki Wolf, who lead his breast cancer foundation and are both BRCA carriers. So again, this would be something we'd love for you to share with your patients if they might be interested. And then finally, Dr. Will Fowkes is going to be hosting his biannual conference in Montreal, May 6th to 9th, 2025. Abstract submissions are due for oral presentations December 2nd and for poster presentations on January 13th. And this site is now open. I think there's a brcasymposium.com, so the .com is missing here. I also wanted to really quickly go through the NCCN genetic familial breast, ovarian, pancreatic cancer guidelines that just came out yesterday. So just some big picture highlights that I wanted to mention to you all. And again, I've put the page numbers of LA 10 of 11, but as well the page number. If you download the PDF, I find that knowing the page number is sometimes useful as well. So I put that in red. So what we did here is for the principles of cancer risk assessment and counseling, we know that a lot of genetic testing is going out outside of a genetics service. So just going through what are some of the minimal components that we still think should be discussed. So this is, again, kind of through point of care testing, what are some of the elements that we still think would be really important to discuss in the oncology or the primary care setting. We also clarified that it's appropriate to test unaffected family members who aren't necessarily the best testable. We had, I had become aware that there are certain insurance companies that are using NCCN to sometimes deny coverage for unaffected family members. And again, that isn't in the spirit of what we were trying to do. So again, we just made it clearer. It's no different in terms of the spirit of what was already in there, but saying it is appropriate to test unaffected family members who meet testing criteria. So that's in these pages, page 9, as well as page 34. For the breast cancer testing criteria, I know a lot of people were probably interested in what we were going to do in view of the ASCO and ASBR guidelines that had come out. So on page 26, we have actually updated the testing criteria for high penetrance breast cancer susceptibility genes, and we revised it to consider testing at or below age 65, and it used to be age less than 60. So that is the change. And we did add a footnote T saying testing includes breast cancer genes plus other inherited cancer genes consistent with family phenotype. And then some other changes related to ovarian cancer. We added a footnote to include some of the other types of ovarian cancer that can be seen in other gene mutation carriers. And then on page 48, so BRCA A205, in the BRCA pathogenic, likely pathogenic variant positive management, we put in a statement about serous tubal intraepithelial carcinoma or stick lesion is found. Further consultation with a gynecologic oncologist would be important. And then for the gene tables, so gene A for ATM, colorectal cancer risk was added, but really we just referred to the colon endometrial gastric guidelines. For BRCA1, we did add a footnote about reduced penetrance BRCA1, R1699Q variant, which has a lower risk of breast cancer, and then indicating that screening should be individualized. And then for CHEK2, the colon cancer or colon endometrial gastric cancer guidelines, the genetic familial one, has removed colon cancer risk as part of CHEK2. So we removed that as well. We also added another lower risk allele. We had the ILE 157 THR already in there, but we added the serine 428 phenylalanine 1. And then again, talking about how additional cancer risk management may not be needed because these variants impart risks of less than 1.4-fold. And then another big one for pancreatic cancer screening on page 52, we added that consideration for pancreatic cancer screening for ATM and BRCA2 carriers beginning at age 50 or 10 years younger than earliest exocrine pancreatic cancer diagnosis in the family, whichever is earlier, and the family history criteria or requirement for these gene carriers was removed. So with that, I am going to hand it over to Carrie to present our first case, after which I'll introduce our eminent speaker today.
Thanks so much. So I'll be presenting this case, which is a 38-year-old male who had done some commercial testing with 23andMe, and he came to Vanderbilt with a report of a BRCA1 pathogenic mutation. He had numerous family members with malignancies, which is what prompted him to get the testing done. He had no personal history of cancer and no personal significant medical history. So this is his pedigree. His parents both had no malignancies. His father was alive, had a history of AFib. His mother had no known malignancy and had developed Alzheimer's later in life. He did have, though, numerous paternal relatives that had cancer. So he had two paternal aunts with breast cancer in their 30s. He had a paternal uncle who developed what was originally thought to be, quote, a bone cancer, but in further medical history records, we discovered that was actually a diagnosis of multiple myeloma. And then he did have a paternal uncle with prostate cancer. Onset was in his 60s. So the patient himself had no known malignancy. He did report that he believed his family was of Ashkenazi Jewish heritage, and then he was unaware of any malignancies in his grandparents. He did have a 35-year-old brother with no known malignancy. So he brought to us his 23andMe testing, and so we recommended, I think he saw originally the genetics counselor team at Vanderbilt, and they recommended formal testing. And so he had in vitro testing done, and he was found to have a pathogenic mutation in BRCA1, the C.5266 duplication, and no other pathogenic alterations were identified. So in talking with him, he originally was tested at 38 with his 23andMe, and I think at the time of his in vitro results, he was just about to turn 39, and he had a lot of great questions about, with his family history, when should he initiate testing? When should he initiate a relationship with urology? In particular, he was really concerned because of his aunts who had breast cancer in their 30s. But in looking at his prostate cancer relative, I think that was a later onset of prostate cancer in the 60s or 70s, or at least a diagnosis later in life. And then he, of course, was asking if he did develop prostate cancer, would that have any different approaches for treatment? He asked a little bit about active surveillance. Would active surveillance be something he would pursue in his 50s if it was a lower grade prostate cancer? And then we also discussed a bit about, for his brother, who was 35, when should he pursue any kind of genetic testing? And if so, when would he have any kind of alterations in his screening in terms of his timeline? So he had a PSA checked prior to our first appointment, and it was 0.22. And then we ended up doing we referred him to Vanderbilt Urology High Risk Clinic, who sees patients with known familial cancer syndromes and are at risk for prostate cancer. And so he had a repeat PSA done, which was still very reassuring, nice and low, 0.55. And he did enroll in a clinical trial that we have that's an observational trial for men with pathogenic alterations. And so he's undergoing routine prostate cancer screening through that clinic with annual PSAs, digital rectal exam, and select MDX testing.
Thanks, Carrie. So with that, I wanted to introduce our guest speaker, who really doesn't need any introduction. So it's Dr. Ros Eeles, who did her PhD in cancer genetics from the University of London, professor of oncogenetics at the Institute of Cancer Research. She's also an honorary consultant in clinical oncology and oncogenetics at the Royal Marsden NHS Foundation Trust, and leads research focused on the genetic predisposition to prostate cancer and management of individuals with BRCA mutations. And again, I think we all know that Dr. Eeles has been a leader in the field of prostate cancer screening in general worldwide. So we are really thrilled to have her join our ICARE case conference as our guest expert. So Dr. Eeles, I welcome your feedback on this last case.
Yes, thank you, Dr. Powell, and also thank you, Kerry, for a very, very interesting case presentation. So maybe there are several things that we would think about. Part of them are genetic, aren't they? And partly how to manage the prostate cancer risk. So if we go to the genetic ones first, this is a common mutation, isn't it? A founder mutation that's been found in the Ashkenazi population. It was found on the 23andMe test. Quite rightly, I think, you didn't rely on that for clinical care. We certainly wouldn't, and you went to an in vitro test. Can you remind me, did you do a full panel? How many genes did you test? Can we go back to have you got the report there?
I think that panel was
Oh, it didn't say at the
that's
bottom.
just a snippet, but I believe we did a full panel for him. We did a 70 gene panel.
Fantastic, because I think that's the first thing to consider. And we've been going, certainly in the private sector in London, following the results presented at ASHG last year. When you have a single gene mutation found, first of all, if it's a 23andMe, you want to validate it in a clinical test, because sometimes these results can be incorrect and one can't manage them on clinical grounds. So first of all, you validate it. And the second is that this family presumably was Ashkenazi in both maternal and paternal ancestries. So if that was the case, you really want to know, could there be another gene alteration there as well? Because some people carry two mutations, don't they? And there was a nice big paper from Holland, from Jan Oostervik, looking at BRCA1 and 2 carriers together, and it was the higher risk gene for any particular cancer that would dictate how you'd manage them. So assuming that you've done the big panel, so they've only got a BRCA1 alteration, and then if they're Ashkenazi both sides, we assume that it's been inherited from the paternal side, because there's breast cancer that side and prostate cancer. But as we all know, it could have been inherited from the maternal side. And actually, there's another gene on the paternal side. So the first thing is, very clever, absolutely right, I think, to do a big panel, because one doesn't want to be caught out. Just as a nuance, I think all of us have seen cases like this. Sometimes you find there are two mutations. So we've got a BRCA1 alteration here in this individual. He's only 38, he hasn't yet hit 40, for which we have most of the data in the world about screening. And we know with BRCA1, the risks of prostate cancer are not as high as with BRCA2. They're about 1.3-fold to 1.8-fold to about 3-fold at most. Whereas with a BRCA2 alteration, it's much higher, nearer 6 to 8-fold. So the data from, again, it's also called the IMPACT study. The data from the IMPACT study, international study, 65 centers, 20 countries, has shown that annual PSA does pick up prostate cancer. So I think absolutely correct to manage him with an annual PSA. And in the original study, the ethics committee only allowed us to biopsy, do MRI and biopsy when the PSA hit above 3. And that was because the ethics committee made that rule, not because we believe that. So the way that we manage patients now is if their PSA doubles in a year, and this one's doubled in 2 years, but if they double in a year or they hit above 3 nanograms per mil, then we do go to MRI, biopsy, targeted biopsy if we see a lesion. And I think at the moment, we don't know in the field whether MRI is a very sensitive method of picking up tumours in these individuals. I really think that's an unknown. And we do need more data in that area. So we're currently doing a study, it's called Profile, where people with BRCA mutations are having MR, and they are having a biopsy and targeted biopsy if we see a Peyronie's lesion 3 or above, with biological markers taken. But to date, if you're trying to manage this individual on current data, you would do an annual PSA from 40. And then one of the questions I noticed in the chat were, if you're doing a prostate risk clinic, how do you set that up and who runs it? And I think it's very different internationally. Our prostate risk clinic is actually nurse-led. And then we wheel and spoke. So we wheel and spoke out to the urologist or the oncologist, depending on what's found. So in terms of management and the screening, annual PSA, trigger an MRI if it goes above 3, or we would actually trigger an MRI if it doubled in a year. Then the next question is, what happens if you find prostate cancer? So say you end up in that situation where you've done an MRI and biopsy, and say they have very low grade disease, something that you do active surveillance, say Gleason 3+3, or even a 3+4 with only 10% or less pattern 4 on the Gleason score. So it'll be ISUP grade 2. Then we would actively survey those individuals if they really wanted us to do that. But the paper from Johns Hopkins suggests that there may be about at least 2, possibly 3-fold chance, relative risk, that they would progress on active surveillance. And it's following that paper that many urologists get very nervous about doing active surveillance in this cohort, and they will go straight to surgery. But that's why we're doing the GenPros study. Again, it's international, funded by CureBRCA. And we're going to look at whether we can validate those data, particularly in the earlier disease setting where you've got very much less disease burden. But the Johns Hopkins paper is forcing some urologists just to go straight to surgery. He doesn't see, I wasn't sure if he had any children, Kerry, as yet.
He does not.
Oh, okay. So the other thing to consider then, obviously, if you're going to go to management, is you might want to consider sperm banking because he's so young. If he's thinking about family planning, because particularly if you're in a situation where you ended up with a PSA that's doubled or it's gone above 3 suddenly, you might end up in a situation where you did your MRI, you did your biopsies, and just very rarely the biopsies cause impotence, don't they? At least even temporarily. So in that situation, you may want to have already done a sperm bank. It's just a bit of a nuance on his sort of age and where he is in life. And then if he ended up in a situation where he did have tumor and he had to have it resected, had a radical prostatectomy, then clearly one would need sperm banking then, and he'd be in the realms of, in the counselling realms of doing, of talking about PGP. So IVF and testing of an embryo and then implanting the embryo, which didn't have the mutation. So it's quite a lot to think about in this family, isn't there? And then if you're testing his brother, so following the one paper, again, there was a poster at ASHG last year from New York showing that, sorry, it was from Philadelphia, where they did predictive testing. And we are now doing this in the private sector. We've gone over to doing this, which we've been doing for a while. But we were vindicated that that was the right thing to do. That if we predictive test now, particularly in a family like this with Ashkenazi, we would actually do a panel for the predictive test, not just test for the BRCA1 mutation. And also, you know, we might be caught out, the duplication and BRCA1 might be maternal, and there's another gene the other side. So that's another good reason for doing panels. So that's genetic comments, comments on the screening, comments on the treatment. If he had more aggressive disease and it was found on PSA screening to be more extensive, then we have a study going on in PET scanning because they have a 3-fold higher risk of nodal mutation on PET scans. At the moment, that study hasn't reported, but we're doing those because of the fact that there is a 3-fold higher risk of nodal disease. So we wouldn't want to miss those in the pelvis, which you could miss on CT on size criteria.
Is that PSMA PET?
Yeah, we would. Yeah. So that's at the moment, I would say that's moderately controversial. They're doing more and more PET in the US now than they used to. But we would do PET because of the early data suggesting from Elena Castro's work that she did with us that there's a 3-fold higher chance of nodal spread. And what you don't want to do is do radical prostatectomy, then find they get a nodal recurrence, you know, within 6 months.
Wonderful. I think you had brought up the 40-year-old onset for starting screening guidelines, and so that's one point that we really struggled with for him. He was not 40 yet, but he was so nervous about that family history, and so I think the urologist opted to start with PSA checks at least, and not more intensive screenings, but at least allowing some data to accumulate in his 30s, but the formal screening to start in his 40s.
Yeah, I think that's relevant. The other thing that, of course, is the MRI. Say his PSA had doubled between 39 and 40, it had gone from 0.22 to 0.44, and then you did an MRI. The MRIs are really difficult to read at that age, and they can often look like they're malignant and they're not. But then, so you end up just having to biopsy them. You don't really have a choice, really.
Okay, so lots of food for thought. Thank you. Carrie, one thing that came up is hearing more about the urology high-risk clinic, how it started. I think that's Jeff Tosian's clinic. I don't know if you want to say a few words and then we can get into Dr. Eeles's presentation.
Yeah,
Sure. So,
yeah.
You know, the urology high-risk clinic at Vanderbilt started with Dr. Tosian's arrival, and he came from University of Michigan. And so he works very closely with Dr. Todd Morgan, who has spearheaded this protocol, and there's numerous sites nationally for this protocol, but it very much parallels the protocols going on in the UK and Israel and worldwide. They all have very similar incorporation of MRIs and lab work so that we can really see how those protocols pan out for these patients over time. But I would encourage patients, if they have a known mutation, to get plugged into one of these high-risk clinics, because I think they're really at the cutting edge of any shifts in imaging. And if you have a patient that is not at Vanderbilt and you want to find a high-risk clinic, I'm happy to get an email from you and help locate one nationally, because I think clinics are very happy to see the patients, and the visits frequently are only once per year, so it's not too much of a travel burden. And we, in our clinic, use nurse practitioners as well as urologists jointly managing the patients.
Yeah.
Thank you, Carrie. We'll go on to Dr. Eeles's presentation now.
Well, thank you, first of all, for asking me just to say a few words about genetic predisposition to prostate cancer and its relevance to targeted screening. Can you hear me okay, Tia?
Yep, we can hear you.
Fantastic. Okay. So I thought I'd just give you a feel for what the gene landscape looks like now. And there've been some real recent developments in this area, and then its relevance to targeted screening. So the first thing is that if you're considering a population and you're looking for predisposition to prostate cancer, we know from twin studies that it's one of the most heritable common tumors, actually. You know, about 58% proportion of the predisposition is genetic, and that's really from studies in twins, mainly from Scandinavia. So highly heritable disease. So there are two types of genetic alterations that we can look for. So the first, very similar to the case we've just seen, are alterations in DNA repair genes. I mean, the most famous, made famous by the Angelina Jolie situation, where she had a BRCA1 mutation. And if she had a male relative, as we've just seen, there's an increased risk of prostate cancer. And the same pertains for the other gene, BRCA2. But it's not just restricted to those, but these are rarer mutations. They're not so rare, actually, in some populations. So, for example, you do have to ask in genetic counselling, you know, what is your ancestry? That can be quite a sensitive question. But if you actually explain why, then individuals understand why you're asking, because it would make a difference to the sort of genetic testing probability that you would find something. So in the UK, these are the instances of BRCA alterations, and as we all know, they're inherited in autosomal dominant way. So if you've got one of these, there's a 1 in 2 chance that for each child or each sibling that they would have an alteration. And as you'll see in a second, it's not just BRCA1 and 2. There's a whole spectrum, a whole panel of genes. So we do panel testing if you're thinking about just prostate cancer risk, and they're all inherited in the same manner. And most are in DNA repair, apart from HOXB13, which is involved in androgen metabolism. Now, the other type of alteration, which is the larger component for prostate cancer predisposition, is polygenic risk. So that's common variation. And in general, we'd say we particularly want to focus on the top 20% of the risk distribution because they have at least a 2.5-fold risk. On the latest panel, on the latest profile, actually a bit higher than that. And I often explain it to individuals that come to my clinic as it's like playing a game of bridge round a table. You've got a hand of cards with your bridge score on it, and that is your polygenic risk score from these variants that you've inherited. They then get the idea that, you know, when you have children, you throw the cards back in the center of the table, reshuffle them round, and re-deal them round to your descendants. So then they get the feel that your descendants don't have a 1 in 2 chance of having this high risk alteration like you see in BRCA, but they have their own score. So for example, your father could have a high score. He's got prostate cancer because he's got a high polygenic risk score, but you might not have that high polygenic risk score. And the question is, now that we know what these variants are, how do they differ between populations? Can we test for them? What's coming along in testing for actually the clinic? So we'll just touch on that as we go through. So the first thing is, have we found everything that there needs to be found? Sadly not. So we already do not know about half of the genetic predisposition. There's clearly more to find. We don't know what this looks like. We are doing one more meta-analysis with Chris Hyman at USC, and including in that more diverse population data, because at the moment, until just last December, there was very little data, particularly on people of African origin and Asian origin. It was mainly European. But now we have finally this Wang et al. Paper on the bottom right, that's in Nature Genetics last December. That gave us what we call the 451 score. And that is the score that we recommend anyone uses if they're currently doing any polygenic risk work. And so you can see here that the SNPs, the polygenic risk, is about 44% of the known component, whereas the higher risk mutations, and they're listed here, are about 7% of the component. So most of these are in DNA repair, with the exception of HOXB13, as I just discussed. And some are more relevant for certain populations. For example, NBS1 or NBN, we see more of that in the Slavic population. So if somebody walks into my clinic, you know, they're from, say, Slovakia, or they're even from Poland, we would definitely be looking out for a mutation there. And that increases prostate cancer risk. It's also more aggressive. And interestingly, recently, we now do not think, do we, that it increases breast risk, which we used to think it did. So these are the mutations that we look for in panels. Mismatch repair are the other Lynch genes, as you know. So we have to be mindful that if we look at ethnic minority groups, the old panel, which is the Conti panel from 2021, that's 269 SNPs. It worked well in Europeans, but it wasn't very good for multi-ethnic groups, as I just mentioned. But the new score found new variants, 187 new variants in the Nature Genetics paper. And some of these were associated with, particularly with aggressive disease as well. And some of them were unique to Africans, and they had a higher per allele odds ratio. And this contrasts a lot with ovarian cancer risk, where, you know, most of that is higher risk mutations, very little polygenic risk, and breast cancer somewhere in between. So with prostate cancer, a lot of the predisposition is common variation. But in the clinic, we're really predominantly at the moment doing these panels. And how do we find the genetic alterations that have led to these results? And there are many groups across the world working together. A lot of them are within the consortium that we run called the Practical Consortium. And you can see over the years, we've accumulated more and more groups that combine in practical and collaborative studies. It's now 133 groups, over 200,000 samples. But the most important thing to tell you is that the latest score is that Wang et al. Paper in Nature Genetics, 451 SNPs. Now, where were we before we had the Wang et al. Paper? And again, this is something I often use to show patients. These are men lined up in a field by their height. And the risk distribution for prostate cancer is very similar to this. It's a normal distribution. Most people are crowded in the middle. But of course, we know that some are at the extremes, like the man on the extreme left, the man at the extreme right. If you imagine there's 100 people in this field, then the man at the right, the top 1%, has an extremely high risk on polygenic risk compared with the middle. It's about 10-fold risk. That's really very high. What we do not know at the moment is if you targetedly screen him, does it make any difference? Right at the end, I'll touch on our recent ASCO presentation, because we now think we do have data. It's just been submitted to the New England Journal for consideration for review. And we now think that we can now enrich to find cases using polygenic risk. But until recently, the jury was very much out on whether you could use this for screening. The second thing is what happens if you are in the top 10%. There's still 2.5-fold risk on the 269 score. So that's before the multi-ethnic score that we've currently got. You might say, why am I showing you this one rather than the multi-ethnic score? I'm going to show you the extra power in a minute. But the reason for showing you this is that we do have data presented at ASCO, as I just mentioned, last summer, using this score. We used 130 SNPs that inform on the 269, and that's because we did a large study in Europeans in London. 5,000 men gave a spit test, a saliva sample, and we did the polygenic risk score for Europeans because that's all we had at that time. And the top 10% of the distribution had MRI, biopsy, biological markers taken. And to cut a long story short, they had a 40% cancer detection, and half of those were clinically significant. They needed treating, and as you can imagine, that's why that paper has been submitted to New England Journal. And those are the results that were shown at ASCO. So it does look like this technique does enrich for cases, and it looks like it enriches for clinically significant cases. So if we split up the distribution, how many cases would you expect to find just on modelling? And if you split up half of the distribution, you'd expect to find just over 80% of the cases on modelling. And this is modelling done by Nora Pashayan at University College in London, who's now gone to University of Cambridge. And so the top 10% would be 34% of cases. So it's interesting that our barcode 1 study that was shown in ASCO found a high proportion of cases. It was 40% in the barcode 1 study. So it looks like doing polygenic risk scores and doing targeted screening for polygenic risk may work, but that's the first paper that really suggests that it might work. But that was only in Europeans. So the question is, sorry, that should say December 2023 now, it's now published. The Wang paper looked at diverse groups. This is the Manhattan plot. And basically, there were a lot of new variants, 187 new variants that were found that were in diverse populations. So you can see here, the 451 score would be expected to find a higher proportion of cases than the 269 score in the highest quintile. So we think that the extra SNPs that have been found in diverse populations, not only will they serve those populations better, but also we should find more cases. And to put it in context, if you look at the risk of prostate cancer of a man of African ancestry compared with a man of European ancestry, he has the same risk at the age of 65 that a man of European ancestry has at the age of the mid-80s. So that really puts it in context that the new score should be able to help screening in men of African ancestry. And this is a table from the paper. You can see that the men in the top 10% of the risk distribution have about just over a 3.5-fold risk compared with the average. And the men in the top 10% who are European have nearly a 5-fold risk. So these risks are really big. I mean, they're like the risks that you would get from BRCA2, for example. And the man in the top 1%, 10-fold risk. And if you're of African ancestry, just over 6-fold risk. So big risks. And the barcode-1 study for the first time, at least in Europeans, suggests that targeted screening in this group really might work, and you might find clinically significant disease. So the next question is, well, if we are going to bring this into the clinic, what sort of models can you use to get risk? And there's the CAN risk model, developed by the University of Cambridge, Anthony Antonio, and he used UK data, UK family data, and he looked at risks from BRCA1, BRCA2, HOXB13, and also polygenic risk. So what he showed, and these are figures from the paper, is that if you had a father with prostate cancer at younger age, you could see the increased risks, the curves going up here. This is the risk in if your brother was affected, which interestingly are very slightly higher, and that's been known for a while. And then the pathogenic variants, BRCA2 having a much higher risk than HOXB13, than higher than BRCA1, which you can see it's only just above the population risk here. And then the relative risks compared with the different polygenic risk scores. But the most important thing is this figure in the paper. I'll just enlarge this now in the next slide, which is the interaction of rare mutations with common variants. And you can see here, for example, if you had a BRCA2 alteration and you had a high polygenic risk score, you can get to really quite considerable risk. So about an 80% risk by lifetime risk with a BRCA2 alteration and a polygenic risk score that's in the 95th percentile. And 2/3 of these tumors on previous data tend to be aggressive. In other words, would need radical treatment. So at the moment, we are not doing a panel, are we, and a polygenic risk score, but it's coming. And in many private clinics, certainly in London anyway, we can do this. I'm sure you've seen this commercially in the United States. So it's only going to be a matter of time before people do come in with these 2 bits of information, and you can put it into CAN risk and then get a risk score. And we hope that for prostate cancer, like with breast cancer, we will soon be able to put in the rare variants and the polygenic risk score for prostate. And the barcode-1 data, I've just described what happened at ASCO this summer. And these were the data presented at ASCO, GU ASCO, prior to the ASCO that's just gone, which was the general ASCO. And this was the pilot data of barcode-1. This was men, European, 55 years and above, because we wanted to sort of model very similar to what you do if you did a PSA in the population, spit test, polygenic risk score for the European score. And the pilot study was just in the first 300 men. And the reason for showing you this is that the overall uptake was not very high. It's only 26%. And in the main study of 5,000 men, it was 22%. So it does look like engaging men, and this is the overall profile of the study. Basically, everyone had an MRI and a biopsy if they're in the top 10% of the risk profile. But engaging men is quite tricky, and only 22% uptake in the main study, as you can see here. And the question is why that's so much lower than in women. It was partly during the COVID era, so that's possibly one reason. And also in the study, everybody was offered biopsy, and maybe they didn't want to do that. But you can see even in the pilot, we were starting to see high-grade cancers in some of the individuals, and certainly 40% of cancer detected in the overall final study, and half of those were clinically significant. And Virtue-Dast in Seattle has found that there's an increased probability, 1.23-fold odds ratio, for upgrading on active surveillance in a continuous variable analysis on polygenic risk score. So the polygenic risk score from the barcode-1 results and Dast's initial study, this was only a poster ASHG, so we're waiting for the paper, could be actually more significant in terms of management than we originally thought, not just a risk assessment. And we worry, don't we, about overdiagnosis. You know, we're just going to find tumours that never progress. The Dast study was worrying and suggests that actually polygenic risk score may not be so harmless in terms of progression. And Nora Pashayan in London looked at Finnish data and UK data, and she found that as you had a higher polygenic risk, you had reduced overdiagnosis. And indeed, in barcode 1, we did not find overdiagnosis was increased. And finally, the impact study, we've already touched on this, looking at that case. This was annual PSA screening. It was pre-MRI era. These are the impact centres. I'd like to acknowledge these at this stage. Thank you very much for your collaboration. And these are the main results from the impact study. These are both published, and these now suggest that you should do annual PSA, certainly at least in BRCA2 mutation carriers. It's now a European guideline, that the alterations in the BRCA mutation carriers, particularly BRCA2, are more aggressive, as I've just mentioned. And the baseline data in Lynch syndrome, we saw tumours in MSH2 carriers and MSH6. We've just found our first one in MLH1, actually, but they're far more frequent in MSH2 and MSH6. And you can see a high proportion have aggressive disease. So just in summary, it looks like the genetic component to prostate cancer is rare variation, mostly in DNA repair genes, and common variants. Common variants are a larger component. We used to think it was only going to be useful for risk. It was only associated with non-aggressive disease. We now know that is not true. It is associated with non-aggressive disease, but it's also associated with aggressive disease. That's on any guideline, NCCN, UK guidelines, any guideline. And the barcode 1 study suggests that polygenic risk score can be used to enrich to find cases. And the DAST poster suggests that maybe PRS might be associated with increased risk of progression. And I think we do need to see more data in that area, but it's possible that you could eventually see the way the field will go is a mixed test with rare variants and common variants. What can you do at the moment? As you probably know, you can just do a panel for the rarer variants, particularly in DNA repair and HOXB13. And we've seen in that case that we just saw presented earlier that at the moment we would do annual PSA with triggers to do MRI. I think the unknown questions are, how good is MRI? The barcode 1 data, just to give you an early look, and it was shown in the ASCO presentation, it missed 2/3 of the cancers at the favourable end of discovery. So that's worrying, because then we don't know how to actively survey them. And even in the aggressive disease that we found in barcode 1, 17% of the tumours were missed on MRI. So, it's possible that we might have to go to biopsy. I'd like to just acknowledge all the people that work with us, because we work in huge consortia, and it's been a real pleasure to collaborate with you guys over the years, and now we're hoping, aren't we, to do a new study together. Thank you.
Thank you so much. That was really, really fantastic. I actually have a few questions for you, Dr. Eeles. One of my questions is, this is simple. CAN-RISK prostate cancer, is that available now for us? Because we use the CAN-RISK for breast and ovarian, but yeah. I didn't think the prostate one was released.
Correct. Yeah, I wanted to show you that paper, because we're hoping it should come out very soon. So we've been working with Antonis, and we're keen for him to try and get that out as soon as possible. We're probably looking to sometime next year. But he has the data. He had a PhD student who's now published. He's got through his Viva, and so I'm hoping that's going to come out soon, because we know that the data are there, and that's why I wanted to show you that. Yeah.
Yeah. No, that's great. So then my other question is, would it be incorporated into the existing CAN-RISK so we could input prostate, breast, and ovarian? Because that would be.
Yeah, absolutely. Yeah, it's got to be in the same interface. Yeah.
Okay. And then my other question, so with Lynch syndrome, I know with the prostate cancer risk, there could be this association with the aggressive prostate cancer, like you mentioned, but then the level of risk is still kind of in question, right? Like more so with MSH2, I think, right, where there might be higher risk, but it's based on super small numbers. So again, I know at the NCCN level that we've really struggled with what do we put forth? Because it could have treatment implications. I mean, there could be this association with aggressive disease, but then risk level is not, I don't think, certain at this point that there is an elevated risk. So would love your thoughts on that.
No, I think you really touched on a very good point. So as you know, the data from Norway and the data also from Manchester, from Barrow's data, suggests, it might be something like a threefold risk. So it's definitely not as high in terms of relative risk as BRCA2. We were surprised to see so many aggressive tumours in the baseline paper for impact. And we've just got to see our UK grant to do follow-up. So I hope with follow-up we'll be able to answer some of those questions in terms of how many new tumours we see. We've just started the follow-up, so it'll be another 3 years follow-up. But at the moment, I mean, I had a case this morning in our MDT. PSA has nearly doubled in a year. So we did an MRI, and the MRI is negative. Should we biopsy him? And we're going to offer him a study because we don't know the answer.
Okay, no, that's fair.
If he had a lesion, that would be different. Yeah.
And then my other question, like when I was looking at your tables for the risks, like European ancestry versus African ancestry was a little bit lower, if anything, with the rest. However, is that a calibration issue because there's not as much data, or do we know yet?
Yeah, I like you was surprised. When I first saw the tables for the paper, I thought, why isn't it higher than it? Shouldn't it be higher than that? And I think it's just amount of data at the moment. Yeah, that's why I think the new meta. So there's going to be one further meta-analysis that Chris is currently doing, and so it'd be interesting to see if it goes up. Okay,
and then my last question, with BRCA, like BRCA2, clearly, I think there's tons of data to support aggressive phenotype, right? BRCA1, I think we all still kind of struggle with. And in our NCCN guidelines, like we have recommend screening for BRCA2, but we say consider for BRCA1 just to kind of differentiate the two. Do you have any thoughts on that? Like regarding data, aggressiveness, etc.?
Yeah, no, I think we're struggling with exactly the same thoughts, actually. So this is why we are so keen. We've got a new study now, which is called Profile, which is where we're offering everybody MRI biopsy, systematic biopsy with targeted biopsy and biological markers, because we, like you, aren't sure that it is as aggressive as the early papers suggested. So I know that doesn't really help you because the patient sits there and says, what are you going to do? But I think there's no doubt at all there probably is some risk, but it's not very high. And some cases we've been actively surveying them because they didn't want any surgery now for several years, and they've been fine. Yeah.
Okay. And the other thing that I was thinking is you have these open studies that we would be happy to send out in case others are wanting to collaborate with you in terms of our partners, because it looks like there's a lot going on. So whatever, we'll just leave it to our partners to decide what is feasible for them. But I mean, these are just amazing, amazing efforts. I'm going to try and get to, I don't see any questions. Carrie, do you have anything that you wanted?
I just wanted to say that was a phenomenal talk and great overview of many important studies. And I in particular think the MRI comments and observations you have are really interesting and concerning. I think that patients and urologists put a lot of weight on MRIs, and so it is interesting to know if there is difficulty visualizing a site that needs to be biopsied. That's very important, and I think I'm looking forward to seeing more data flesh out on that.
So I'm going to just try and do one case because we're going to be out of time soon.
This is Jeff Whitesell.
Yes.
Yeah, Ros, awesome. As always, awesome. I'm just thinking about the future in terms of platforms. Clearly you're showing the benefit, or especially in prostate, the benefit potentially for filling in some of the heritability for prostate. And I know that you've done very innovative work with whole genome sequencing at the clinic level. And it's clearly seems to me that that's a platform to get both your gene level risk and your PRS risk, including principal components, as a unified platform. Just one, give me the future for you.
Yeah, absolutely. So what Jeff's alluding to is we did a whole genome study in primary care, looking at whether it added to medical, at a GP's surgery. I think from that, it is possible, Jeff, that we'll be able to just do very big panels and then do skinny whole genome to get polygenic risk score, put the two together. But, you know, if the costs of whole genome came down and also you could do long reads, then I think, you know, the future is very, very exciting.
It is. Thank you.
Okay, I'm gonna blast through this case really quickly and get Dr. Eeles' quick thoughts on this. Carrie, this is a shared case with us and you. So it's a 60-year-old elevated PSA, familial PALB2 mutation, family history of triple negative breast cancer, December 2020, was referred to urology for an elevated PSA 3.67 compared to 2.29 in 2018. Brother had metastatic prostate cancer and a PALB2 mutation. So the patient was tested, has a PALB2 mutation, the C2718G to A, had a prostate cancer biopsy in April of 2021 and had a Gleason of 6. And here's the family history. It's basically what I had said. So here's the proband. And then we have this family history of prostate cancer, another brother with prostate cancer, and then a sister with triple negative breast cancer. So again, it was low risk because it's a Gleason 6. Urologists discussed active surveillance versus surgery versus radiation. There was a follow-up oncotype DX testing that was done, and it was shown to be low risk. And a repeat prostate biopsy again showed a Gleason 6. So there are multiple family members that hadn't been tested when we saw the patient. But really, the question here is, how do we take family history of aggressive prostate cancer into account to potentially guide treatment? And patient was concerned given his brother had aggressive prostate cancer from which he died. So is this an indication for prostatectomy? Carrie, I don't know if you remember this case, but it's kind of an interesting case. And it was at the time when that paper from Poland came out with the prostate cancer survival and PALB2, which again, I know has been shown in the Polish population, but we don't know what's, you know, in other populations, what the case is. So would love your thoughts on this.
Yeah, this is really tricky because, as you say, some papers, and it may be population specific, suggest that PALB2 really might behave in a very aggressive way, and other people's data have not found that. And then the question is, does it behave in the same way in one family? So if you look at Vickland's data, it suggests that that is the case. We had a paper in about the UK data, and we surprisingly we didn't find that, but we only looked at family history. We didn't have specific genetic alteration results for that paper as yet. We will have soon because we've got Regeneron data coming through. So it's very difficult, isn't it? I mean, you get very nervous about somebody with this sort of family history, and you wonder if, does it breed true, in other words, because, you know, we do see it, don't we, with other genes. On the other hand, his oncotype test is low risk. I think we probably would, as a minimum, we would follow this man really, really carefully. Yes. And I notice you've rebiopsied him, which I think is very, very sensible. And we possibly even would do a third rebiopsy. So if you've got a biopsy, is that a year after his first diagnosis, you rebiopsied him? Yeah. Then we would probably rebiopsy again about, 18 months to 2 years if his even if his PSA stayed down, if he wanted to be actively surveyed. But most people would be very nervous about watching this man for a long time. I know that doesn't really come down one side or the other, but those are the thoughts that would go through our head.
Yeah, no, we appreciate that. And Carrie, we should probably talk to Dr. Tosian about this one, this patient.
Yeah, if I remember correctly, I think they started with active surveillance, but at 60, and I think he was otherwise very healthy. It's a long time of active surveillance, probably repeat biopsies, and I think I remember he was quite anxious, and so
He was anxious. I remember seeing him and he was very anxious.
understandably, given his brother's history. So, yeah,
Yeah.
these are, the tricky cases. Absolutely, no, absolutely right answer.
I have to say, in our clinic, I think we probably would have lost, particularly if somebody is very, very anxious, and the patient also is shared decision making, isn't it? I'm sure somebody like this would come to surgery within a year, 18 months. Yeah, we certainly would. Certainly, somebody would rebiopsy. So I think that was a really wise thing to do.
Well, with that, I know we're a couple minutes over, but thank you, Dr. Eeles. This was really, really a phenomenal learning opportunity, phenomenal presentation as always. Just looking forward with our upcoming case conferences. Our October case conference is going to be led by Dr. Alvaro Montero, focused on BRCA hypomorphs. And then in November, we have Dr. Antonis Antonio lined up to revisit CAN-RISC. I think it'll probably be too early for the prostate to be incorporated, but we can certainly ask him about that when he joins us for case conference. This is our upcoming schedule. We also actually, I guess we have a big UK representation because Dr. Mark Tishkowitz is going to be joining us for PAL B2 in January of 2025. So with that, I thank you all for attending. I thank Dr. Eeles for agreeing to be our guest expert, and we will see you next time. And we will send out some of the studies in follow-up that you may be interested in participating through your patients with Dr. Eeles. So again, big thank you, everyone. Bye.
Thank you. Bye-bye.